Welcome to Q1 MHP Primary Care webinar. This year we'll be having 3 different webinars, one for specialty care, one for adult primary care, and one for pediatrics. This is an effort to try to make sure the information that we're providing is meaningful to each specific group. I wanted to tell you a little bit about Mission Health Partners strategic goals. As you know, we're aligned with the quadruple aim and focus on quality, cost effectiveness, and patient experience. But we also want this to be the network of choice for you and your practice. We want it to be the best financial option for your practice, and we want to provide the best possible care coordination. In order to do this, we need to do a lot of work in terms of communicating to you what we think are opportunities for us to do better as a network, and we also want to hear from you where you think we could be working with you to improve processes and improve clinical outcomes. Our strategic timeline has a specific focus for each quarter. The things that you'll want to know about are the areas of focus in our clinical processes. This quarter, we're going to be focusing on attribution, annual wellness visits, and advanced care planning. For the primary care practices, it will be important for your practices to engage with us in terms of looking at our Medicare Advantage plans and their attribution lists and making sure that we correct these where it's appropriate. We'll also be providing you resources for annual wellness visits. Many of you are already doing this and doing a great job. Some practices less so, but we want you to have the information you need to try to get your patients in and do a good job with annual wellness visits when possible. The other thing is we feel like there's a great opportunity to do a better job with advanced care planning, also to make sure if we have the opportunity to get advanced directives in the chart, that we show you how to do that through the Health Information Exchange and make sure you can work with us to make that happen for patients. Other areas of focus will be promoting interoperability. This is a big issue for us this year. We have a lot of work to do around making sure we are integrating a referral process, making sure patients are using the portal, and we'll be communicating with you about that on a regular basis. Managed Medicaid will be another big focus in 2019. We expect to have much more information over the next 2 months, and we plan in Q2 at our next in-person meeting to have conversation with you about our care management strategy and our plans moving forward. Many of you have already been focusing on the annual wellness visit in your practices. It's a great way to make sure you're meeting our quality goals, as well as making sure patients have the appropriate attribution to you in the network. Some of you have focused less on this. Our goal over the next couple months is to provide your practice leadership during the practice manager calls with resources and education on the annual wellness visit process. We have a podcast on annual wellness visits, and we will have a folder, a Q1 folder on the MHP app where resources for the annual wellness visit can be found. So, for example, if your patient screens positive for falls, we'll have the information about referral to the YMCA or other resources for providing support to patients who need that additional resource. So have you had an annual wellness visit?
I think I've had 2, and I remember one fairly clearly, the most recent one.
So did you find that it was beneficial, or?
At the time, I didn't feel it was. Didn't feel like she asked appropriate leading questions, but I didn't feel like she was talking about anything that my doctor didn't already know.
Really?
Yeah.
Is there something that could have made that visit more valuable to you?
I'm not sure. It was a woman I'd never seen before. The previous time it was a different person. I think as different things happen to me, then obviously that gets into the general record. Mm-hmm. But I never knew with whom that was shared, mm-hmm. or if the person doing the interviewing had read the previous record.
I understand that not all patients are enthusiastic about getting their annual wellness visit. It can seem redundant or not of high value to them, particularly if they don't have a lot of chronic problems. So developing a way to communicate to them the value of the annual wellness visit to make sure they understand how it helps us in coordinating their care throughout the year, and to make sure the people who are providing the annual wellness visit are well informed and can give them the best service possible during that exam.
Annual visit has been good in that I feel that I really have somebody who has the record and who knows what all has happened medically to me.
Do you want to talk about when you had an annual wellness visit and what you thought was helpful or not so helpful?
I thought it was pretty good because the pharmacist broke down each medication, how many milligrams I was taking, to make sure that I was taking the right meds for the right thing and I wasn't overdoing or whatever. They found that there was 2 medications that I was taking that were basically the same with 2 different names that was for the same purpose, so she took one out. The one that was less potent, she took that one out. But going to the wellness, it can be a preventive thing, which is a good thing.
There are 2 areas that we think you could focus on during those annual wellness visits, particularly early in the year. That would help us overall as a network. One of those areas is if the patient is a diabetic, if we could get their A1C result as early as possible. I know many practices are reporting those results towards the end of the year. If we know a patient is poorly controlled and you don't have the resources in your practice to provide nutrition support or pharmacy support, we can help coordinate those support systems on our end. The other area is advanced care planning. Overall, we're not performing as well as we would like as a network on this, and we hope to have this as a measurement in future years, and want to be collaborating with community organizations on supporting patients in getting their advanced care plans into the electronic health record. So the annual wellness visit is a time where someone can help make sure we get those documents and get them into the medical record. I'm a big believer in making sure that we have team members that can help us, help patients complete their advanced directives, get copies of them, get them into the electronic health record, get them into the HIE, and do the annual wellness visit to make sure that we have those documents and to talk to the patient. But we aren't off the hook as providers, and I think we do well probably when patients have terminal illnesses, making sure we have these conversations. We don't do as well when patients are doing fairly well and acute event happens. And I think this is where we see that we, even though patients may be very clear about what they want, we don't have it in the record and we don't have a plan. And so it's our responsibility to try to make sure we have these conversations earlier on. And particularly before we do a surgery or before we order an expensive procedure or diagnostic test, we need to understand what the patient's ultimate goal is and whether this is going to add value for them.
I think that happened in a kind of awkward way. She went in for a colonoscopy and had a puncture and had sepsis, and that was after my dad's situation, and everybody said, "Oh yeah, we can take care of that, no problem. Everybody takes care of that." Well, yeah. So she had an ostomy whole bag and all of that, which she refused to deal with. And I think that's essentially what killed her. But eventually, she just died because she wouldn't eat.
Mm-hmm. So about making decisions outside of, what's appropriate and what's not, what do you think providers could do to help you understand what?
Just explain what all the realities are.
Mm-hmm.
And in my mom's case, it was kind of a rushed thing because I was in Raleigh, wasn't even at home up in the office. I was in Raleigh, doing a consultation, and got the call and hustled over to the hospital where she was. And it was make a decision now because we need to do it immediately. Sepsis is an issue. So I said, yeah, go ahead and do it.
Did somebody present you with the option of not doing it?
No one was talking about not doing it. Nobody explained what would happen if we didn't do it, but I think I had a pretty good idea.
Mm-hmm.
She would die of blood poisoning and system shutting down.
What my father didn't say is that my grandmother was really, really upset about this and upset that she ended up with the surgery that she didn't want. She had advanced directives and had communicated them. It was pretty clear in that document what she wanted, but it wasn't available at the time that the decision was made, and I don't actually think it addressed this specific circumstance. So my dad was in a situation to make a decision on an urgent basis that he couldn't really predict what it would mean to her. And she was upset enough about it and unhappy with the outcome that she chose not to eat and ultimately decided to go into hospice and ended her life with lots of support. But it was really, really tragic, particularly for my dad, who had been put in the position to make a decision for her in this circumstance.
Well, the studies all show us that the longer we know a patient, the less accurate we are in our prognosticating. And I think a lot of it's from the emotional connection that we have with our patients' primary care docs. The discomfort that most people have with having that discussion surrounding end of life or surrounding the transition of care from a truly curative mode, which is what we're all geared towards. When you hit the emergency department or you hit the hospital, you know that we're going after this disease and we're going to cure whatever's going on, or at the very least, get it highly controlled. To be able to start that conversation about the transitions of care and making it not about curative anymore, but about symptom control and about quality of life, and not about just extending length of life, but looking at how good is the quality that I currently have. Starting those conversations early makes it much easier to have that discussion versus when a person's in crisis, when they're in the emergency department and a person is not able to breathe easy. That's not the time to start a discussion about what do you want us to do. I want to breathe. That's the priority at that point.
Black people rarely speak about that. They don't sit down and tell you what's that, what's this.
Do you know why?
I think it's fear.
Fear of dying?
Yes. Fear.
Yeah, I think we all have some fear of dying.
Well, yes, I do too. But there's something going to happen, so why fear it? It's going to happen.
Mm-hmm. Do you have any specific examples where you saw an opportunity where if we were communicating well or communicated well with the patient, that the outcome would have been different in a positive way?
Well, I guess it depends on how you define positive, but there are, countless examples of, people that have had, pretty aggressive CPR, intubation, interventions within the ED that we find out 30, 40 minutes later, an hour, when family finally does arrive with that piece of paper that, they really didn't want any of that. And that's kind of always a really bad feeling for at least the providers and staff involved in those cases. But at the same time, I have had cases where they have shown up and they've obviously been, very sick and heading towards the end of life with that piece of paper. And it does really help, especially if they've got the most form and maybe a little bit more details other than just do not resuscitate it, as far as exactly, how aggressive that they want their treatment to be. And in those cases, it is extremely helpful.
That it's really a process of beginning a conversation about how people feel, how they want to be cared for, if they were to develop medical complications or, they were coming to the end of their lives. And I think that's a really important and helpful perspective because it makes it apparent that number one, when you do advanced care planning, it's not a one and done. It's a process, and that it's a process of really beginning a conversation and beginning a conversation not just between you and your patient, but also starting that conversation between them and their family or the people they love. And I think most importantly, from at least from a legal standpoint, the people that will be having to make decisions for them in the setting of a crisis. I think that the other thing that becomes apparent when you think about it in that way is that the conversation will be different for different people depending on where they are in their lives. So that, if somebody is young and healthy, that it's going to be a very different conversation than if you're seeing somebody in follow-up after a recent hospitalization for a stroke or a COPD exacerbation.
We heard from physicians that one of the challenges with advanced directives is actually finding them in Cerner. So one thing I wanted to do today is show you, if you are in Cerner, where to find the advanced directives. You will notice when you're looking at your screen on the top banner bar, there's a section that says advanced directives, and you may see a yes or a no there. When you click on that, you actually can't pull up a document. And the purpose of this field is for the initial intake screening. We ask the patient if they have an advanced directive, and that yes or no is what actually completes the field. There may be also others involved in that screening process who complete a questionnaire and enter the yes or no in that field. That field may not actually correlate with whether or not there is an advanced directive in the chart. In order to find the form, if there is an advanced directive, you need to go to the side bar, the menu bar, and there are two areas where this can be located. If the patient submitted their advanced directives through the Health Information Exchange, you can click on the area that says Exchange and scroll down once you enter the exchange, and there's an area in the middle section of the chart on the exchange that is specifically for advanced directives. If a document has been scanned in through the Health Information Exchange, you should be able to pull it up through that process. The second process is an advanced directive that was scanned in through Cerner. Those documents are found again through the menu bar. If you click on Clinical Notes, you will see under Administrative Notes there is Advanced Directives. When you open that up, you will find at the top of those documents the most recent advanced directive scanned into the chart. There's a team at Mission working on the advanced care planning process through annual wellness visits, as well as the documentation of advanced care plans. And we will be working on the most efficient ways to make sure you have access to advanced directives. As this changes, we expect to communicate that to you so that you understand the best way to get that communication.
I think that one of the big focus or foci that we could use this year for advanced care planning would be those collaborative agreements between the specialist and primary care docs to be able to say that we're going to define who's going to take care of what part of this particular disease process. Example being in a pulmonology practice, the pulmonologist may be dealing with a patient with pulmonary fibrosis, and has not had any discussion about the long-term effects or what the end-stage disease might look like. And the primary care doc is kind of expecting that the specialist would add to that discussion. So to be able to actually delineate that in an agreement about what I'll cover and what you cover may make it easier to start having those discussions about advanced care planning. From a primary care standpoint, probably the same type of approach would be useful, but to look at chronic diseases that we see over and over, the CHF, the COPDers, the ones that are the likely to be high utilizers and end up more frequently in the emergency department or with readmissions, to look at those patients to say, this patient's needs are increasing. Do we have an advanced care plan in place? And to make that advanced care plan specific for that patient, for the current situation that they're in. And once we have that, particularly in the primary care office, to make sure that it's visible. And that's the challenge that we've faced more often than not, is to make it visible in the medical record. Is it going to be visible in Cerner? Is it going to be visible on the office record?
I think, the other thing that's changed dramatically when you talk about advanced care planning is that you can now bill for it. Any provider that has spent more than 16 minutes of their time, discussing advanced care planning, can bill for that work, which is amazing, and is I think because it's really it's finally giving some support to what's really core to what we do, particularly in primary care, in the primary care setting. Communicating with people about their diseases and the implications of their diseases, and trying to understand them and make sure that our healthcare, the decisions we're making are aligning with what they want, to help them live their lives as best they can.
Death and dying is not frightening to me. Just, I know that it's inevitable, and it's a series that you have to go through. You might not like what you have to go through, but you don't have a choice.
Patients tell us that it's important to them that we communicate with each other among specialists and among primary care and specialty care. One of the things that we want to do as a network is to improve that, and part of that can be improved through the referral process, but we're asking this year that all specialty teams develop a co-management guideline. And you will see this is an example of what the co-management guideline looks like. As I've already visited some practices and talked to some specialists, they may first focus on areas where we can improve the referral process, where workup might be done in advance to make sure that the appropriate referral is done and that the information is available that's needed. And the form helps you walk through that process. There are other specialists, for example, in cancer care, where they're most interested in, once treatment is completed, making sure that patient has a primary care provider, and that primary care provider does the appropriate follow-up and reconnection with cancer care as needed. Where do you see that we have some opportunities to do better?
I think, as far as I'm concerned, there's two ends of the spectrum. We see many patients, or particularly I do, because they're generally a healthier population who might not have a primary care provider, and we would love to get them connected, but it's very hard to facilitate that because you don't know who is taking patients and what insurance that person may be taking. And as we talked earlier, I think it'd be wonderful if we had some liaison from Mission Health Partners that could help facilitate that. So I think on the back end, how we can better communicate back with what the care plan is, the side effects they should be looking for, and then what kind of follow-up imaging modalities are appropriate.
From the inpatient hospitalist or hospital-based physician perspective, there's an opportunity to focus on care plans. This could include advanced care plans and the processes around advanced care plans, or it could include how to best communicate around discharge planning with the primary care provider or the provider who will be taking over care once the patient is discharged. Again, I'll be meeting with teams and hope we can work on this to develop some effective processes that will bring value to patients and to us as a team, and make sure that once those co-management guidelines are completed, they will be approved by the quality committee, and they will be available for team members on our webpage, and we will make sure they're available to you on the phone app.
Everybody is in sync. You know, they're all in sync, so they know, everybody knows that this happened, when it happened, why it happened, and what this one is doing and that one is doing. Your nephrologist is taking care of blah blah, so I don't need to put you on yada yada. They're all working like as a team, which it is a good thing. It's a good thing. I don't have to worry about what this one is doing or what that one is doing, because they all know what each one's doing.
There are several things this year that we want you to be aware of related to promoting interoperability. Now, promoting interoperability is the same thing that meaningful use was several years ago. Then it became ACI, and now it's promoting interoperability. There are a couple areas that have changed for the 2019 reporting, and we're going to have to start early in the year in order to ensure that our performance is good by the end of the year. And this performance is so important to us because it actually impacts our rate increases. So the first thing that we want every practice to do is ensure that they're on a 2015 certified EHR. Once that's happened, we want you to confirm that you have a message address that we can send referrals to. Some of you have already tested this, and early on in the year, we'll be working with practices who are ready to go on ahead and test the referral process. So one of the main areas in promoting interoperability this year is that we will test the referral process electronically to specialty practices, and then make sure that there's confirmation in the primary care practices that that referral was received and that information was received back from the specialty practices. This will obviously take some time, and the ultimate score at the end of the year is based on performance and percent of use of that electronic capability. One other area in performing interoperability that we want you to be focused on is the portal use. For those of you who've been doing this for a while and have a high volume of portal use, it may not be an issue for you, but particularly some of our smaller practices or our specialty practices that don't have a lot of communication back and forth in the EHR, we need to focus on this area as well. Once we get into the second and third quarters, we will be testing, and you should be able to submit your performance and see what your score is, and we'll be working with you to optimize that. And the measurement period is a total of 90 days that will be measured by the end of the year. So as long as we start working on it now and we test and are getting measurements mid-year, we'll be able to optimize your performance in PI by the end of the year. If you have any concerns about your practice's ability to achieve with promoting interoperability and you need some additional support, please reach out to MHP. We have a great partnership with them, and they may be able to support you in your practice in achieving the specific transitions related to promoting interoperability that you will need to achieve this year. This slide is a summary of the adult primary care metrics. There are a few changes this year. Hopefully you'll find it a little simpler than the quality plan last year. As you'll see on this form, that the Tier 2 and Tier 3 metrics are exactly the same. The only difference is that there are different thresholds based on Tier 2 and Tier 3. As a result of this, there's actually fewer measures. However, there are a few new measures. Some of the new measures are around our Medicare Advantage plans, and you will see those at the top. We are asking for reporting out on readmission rates as well as medication reconciliation after discharge, and we will be focusing on hemoglobin A1C control in our Medicare Advantage plans. All of these metrics are high value. Our diabetes metrics for Medicare Advantage plans are triple weighted, and so we want to focus on improving performance in this area. The other adult quality measures are essentially the same. We have a new measure that's specific to Medicaid. You'll see that cervical cancer screening is a new quality metric for the adult practices. And we also have a new metric around promoting interoperability. As you go through the process with your practice of testing your performance in promoting interoperability, you will be getting scores, and we will be working with you to get the highest score possible as we report towards the end of the year. Your performance on promoting interoperability has a significant impact on the network as a whole in terms of our rate increases. So we want to make sure that you're focused on this improvement process so that we perform well. So we will have thresholds for all of these measures that will be available to you at our Q2 in-person meeting.
Hi, I'm Kelly Terry, Provider Relations Rep for Primary Care. To get credit for watching the meeting today, you'll need to go to the MHP Connect mobile app and enter this code, VKTR19.
In closing, I would just like to review some key take-home messages. Please remember to support your teams in working with us on improving the attribution process. We'll also give them some resources to help support them in scheduling annual wellness visits. And as you're doing annual wellness visits, that may need to be delayed until flu season ends, but the earlier in the year that you can do that, the better. For all of our Medicare Advantage plans, they don't have to be 12 months apart, so you may be able to avoid some of the busyness at the end of the year if you go on ahead and schedule those patients earlier on. Also, in those visits, if they have diabetes and you can get their hemoglobin A1C reported out, that would really help us address those patients who are in poor control. Again, with promoting interoperability, you need to be upgraded to a 2015 certified EHR, and we need a group address to send referrals back and forth. And we'll be working with your teams on that. And MAHEC is available for support with PI if you need it, and so we can help connect you with them. And lastly, support your teams in getting advanced care plans in the Cerner system. And again, there's two ways to do that. If you're in Cerner, you can scan it in. If you're not in Cerner, you can enter it in the HIE. If you're not connected to the HIE, we can help you get those into Cerner. And so please let us know, and we'll be working with your practice management to help them understand how that process works. There are also 3 new HCCs you should be aware of this year. One is stage 3 kidney disease. That was not considered an HCC last year, but it is this year. Also, personality disorders and substance use disorders are also considered HCCs this year. So be sure to include those as you're being sure to document HCCs. Thank you for joining our Q1 Primary Care webinar, and I look forward to seeing you at our Q2 in-person meeting. Have a great week.